Almost tripped there. So I bring sunshine from Florida. So welcome. It's my pleasure to be here. My talk today basically is going to be on biofilm and really demystifying wound infection in general, and just looking at perhaps some new innovations. These are my disclosures. So first and foremost, I think it's important to define what infection is and how it really has an impact on wound healing, describe biofilm and its unique characteristics, elaborate on what biofilm really does in wounds. You know, not all biofilm is bad. If all biofilm was bad, no wound would ever heal. And then maybe identify some of the challenges that biofilms have in treating infection and healing wounds. So what's the problem? Well, microbiologic infection, of course, is the single most important reason why chronic wounds don't heal. Typically, they form biofilms, which are notoriously recalcitrant to any kind of antibiotics, both topically and orally. And they're really an ever-growing concern from a public health standpoint as well, because we see them in other diseases, such as cystic fibrosis, and we believe in Crohn's disease as well. And of course, these are traditionally intolerant to traditional antibiotic therapy. So when you look at wounds and you look at bacteria, all chronic wounds are contaminated. You know, when you hear about bioburden, you think, oh, well, that's a bad thing. Well, all wounds are contaminated. And of course, they do heal in the presence of bacteria. And in fact, some bacteria actually facilitate healing. Thus, the presence of microorganisms alone are really not the issue. It's really the amount and also the host response. And I think what tends to happen very often with the host response is people ignore the fact that you're dealing very often with a sick person. So looking at the biologic continuum for bacteria, of course, contaminated and colonized wounds don't really have an adverse effect on wound healing. It's really when they become critically colonized, what we now call a cult infection, or when they become infected, either locally or systemically, that's really where you have a problem. So of course, there are local and systemic factors that will impede healing. The big one, of course, is inadequate blood supply, foreign bodies, infection, of course, age is a very big issue here, smoking, and of course, diseases such as diabetes and malignancies. And of course, there's a big difference between treating patients with local disease and patients with systemic disease. So thinking in terms of infection in general, of course, we always look at the virulence component, you know, strep being certainly much more significant than staph in many cases. But what we also have to look at is the dose. How much are we dealing with? What is the quantity? Thirdly, and I think probably just as importantly, is the host response. What is the patient able to do to heal an infection when it occurs? So infection really is virulence times host over host resistance. Signs of infection: heat, pain, redness, and swelling. These are things that we see historically and we expect. But unfortunately, very often, we don't see that. We don't see it in the immunocompromised patient. We certainly don't see it in the patient who has biofilm. So very often, we have to look at what is commonly referred to as secondary signs and symptoms of infection: friable granulation tissue, pocketing at the base of the wound. And the big ones are most significant wound deterioration. So you're doing all the right things. You're offloading in a diabetic patient, as an example. You're compressing in a venous leg ulcer patient, and the patient's just not healing, and in fact, the wound is getting worse. And also pain in an otherwise painless foot. You have a patient who's had neuropathy for 30 years, hasn't felt the bottom of their foot for 30 years, and the next thing you know, they're coming into your office and saying, I can't walk, I have pain right here. So certainly that is a big indicator. So in making a diagnosis, very often it's not so easy to determine whether or not a patient has an infection. Again, you have to be looking at those primary and secondary signs of infection. And of course, everyone in this room knows that you don't culture every wound. And if you use a swab culture, basically swabbing a wound is like swabbing your shoe, because the bacteria that you're going to see in the wound is going to really be identical. Tissue biopsies are better, but we have to find some better way to evaluate these patients, particularly from a biofilm standpoint, because traditional swabs really don't do it. Culturing methods, of course, have changed. We now have PCR testing. Dr. Jacobs had pointed to this. This is still controversial. We see a lot of different pieces of information. We know that we're looking at biofilm when we look at a PCR culture, but we really don't know which ones they are. It does really, though, help us with our sensitivities and using the appropriate antibiotic if necessary. And of course, debridement, extremely important in removing devitalized tissue. So infection really complicates wound healing in a number of ways. It damages tissue, it reduces the wound tensile strength, and of course the biggest issue is it creates this constant state of inflammation. So the wound cannot move from the inflammatory phase of wound healing into the proliferative phase of wound healing. So it's really very important to keep an eye on this and to treat infection when it's there. So let's move to biofilm. Biofilm is not new. It's been around since the 40s. Was first reported really in 1977. We see it in hot springs and glaciers and oil and gas reserves. We see it in sewage plants. We see it in the bathtub rings in our houses, in our toilet bowls. We see it everywhere, really. It's ubiquitous. Now, one place we see it in medicine is in dentistry. And the reason why we didn't really know that before is because we don't really often read the dental literature. So why do people who have tremendous biofilm in their mouth, why don't they have chronic infections? Well, because they're constantly debriding their mouths with toothbrush, or they're using Listerine, etc. So very often, though, this is what they miss. So you think that you're getting what you need, but you're really not. So what is a biofilm? Well, a biofilm is a community of very virulent organisms, bacteria and fungal organisms, and they're enveloped in this glycocalyx, what we call an EPS. And this glycocalyx is very, very resistant to anything moving into it. And it's also attached with metallic bonds, so it really is a very, very solid structure. It becomes a very resilient barrier. And what this does, what this glycocalyx does, and I'll show you a picture of it in a few moments, it protects the bacteria from antibiotics, any types of antibiotics, whether it be an oral antibiotic or a systemic antibiotic, from really getting into the area. So I think you'll be surprised to know that most bacteria really do exist in a biofilm. 10% are planktonic. Planktonic bacteria are very important in forming biofilm because the planktonic free-floating bacteria attach themselves to a structure, create a mature biofilm, and then seed elsewhere. 90% of bacteria are actually biofilm. What's really interesting, in my view, is that it's 1,000 times more difficult to treat than planktonic bacteria. So biofilm is present in chronic wounds. We also see it in acute wounds. And again, if biofilm was bad in every case, then no wound would ever heal. So they're not always bad, but when the wounds are not healing, we have to really think biofilm, because particularly in the diabetic patient, 100% of bacteria are biofilm. So can you see a biofilm? Well, you may hear lectures, and very, very well-known people will say, well, here's the biofilm. You can see it. It's right here. You can't see a biofilm any more than you can see Staph aureus. It's microscopic. What you're seeing is the effect of the biofilm. And of course, you have to do a culture of some kind, but these routine cultures very often do not tell the story. And the only thing we have currently is the PCR testing, which again is controversial. So when you're looking to identify a biofilm, very often you don't see heat, pain, redness, and swelling. So you really have to do a comprehensive physical examination, looking not only at those primary signs and symptoms, but secondary signs and symptoms as well. So why are bacteria within a biofilm hard to heal? Well, you have this glycocalyx, mutually protects with something called quorum sensing. Quorum sensing, basically, the genetic material is talking to itself and protecting the situation. These bacteria are quiescent, which means that antibiotics won't really work well with them, and they form really rapidly. They're back in 24 to 72 hours. Take a look at this. Only fluorescent bacteria are metabolically active and only located on the outer side of the biofilm. So antibiotics will only kill those active antibiotics. Professor Robert Koch, he probably was 30 years old in this picture. That's how they looked back then. This is in 1884, one germ, one disease. So he really was looking at planktonic bacteria alone. We know now that that is not the case. But this is what we're dealing with in most scenarios, at least we think we are, and these are the cultures we take. Well, these cultures have been taken this way for decades and decades and decades. They're no longer applicable in many cases, particularly now that we're dealing with biofilm. I just want to give you a sense of what a biofilm really looks like from an architectural standpoint. It's kind of scary when you think about it. It has its own water channels. It has microcolonies. If those of you are old enough to remember the blob, that's kind of what it reminds me of. So biofilms don't play fair. They're very difficult to culture. They're tolerant to biocides. They're tolerant to antibiotics. And they're capable of regenerating. So why resistance? Well, biofilm, again, is reduced because you have the glycocalyx that doesn't allow penetration of antibiotics. Cells within a biofilm grow slowly. These quiescent bacteria are not going to have any effect from antibiotic therapy. And lastly, cells within a biofilm express many stress response genes, and these are resistant to antibiotic action. Here's a host cell surrounded but unable to penetrate a Pseudomonas biofilm. What I wanted to talk about here is as you get more and more bacteria forming, you get this phenomenon called quorum sensing, where the genetic material is actually talking to each other, and they're saying, get out of the way, you know, there's something coming towards you. So it's another layer of protection. So just to give you kind of an idea of why you can't see a biofilm, this is what a biofilm actually looks like. Okay, and as we get closer and closer with electron microscopy, you can see what that glycocalyx looks like. And think in terms of the fact that the bacteria itself is sitting in the center of this tube, sitting in the center of the tube. So it's not covering the whole tube, it's right in the center. Here's just another example. So if you look at this wound, or group of wounds, you could say, well, this is a biofilm. Well, this is probably showing the manifestations of a biofilm, but again, you don't see the bacteria. Okay, this obviously is a case where the patient has peripheral arterial disease as well, but biofilm really could be considered a diagnosis of exclusion. Now look at this. After 60 minutes of exposure to dilute bleach, Dakin solution, many bacteria in this biofilm were dying, but many lived. Pretty scary when you think about it, okay? And the same thing happened with tobramycin. Now this is really very important because sharp debridement, which we know is extraordinarily significant when you're dealing with a biofilm model or any bacteria in general, there's a time-dependent window, okay, that kind of closes after about 72 hours. This was a study done where they took biopsies and they put them either in saline or in gentamicin. They followed them for 3 days. At the end of 3 days, that mature biofilm had returned. So you have the situation where you have a window of opportunity, but that window of opportunity closes very quickly. This was a monograph I was involved with, and what I wanted to share with you is some work done by the late Greg Schultz, who is a very good friend of mine, a colleague and mentor, and he had the step-down effect, looking at dealing with a biofilm model very, very aggressively on the front end, the first couple of days, you know, doing the appropriate culturing, debriding aggressively, perhaps seeing these patients on a very regular basis. And then over a period of weeks, getting to a point where you could start using standard care. But something that's often missing is you need that biofilm disruptor in this model, and very often that's missing, and there's a reason for it. So the optimal biofilm treatment really requires not only dismantling this glycocalyx, destroying it, but making sure that you're not getting recolonization. So this was a study that was done, and we kind of looked at various things that could be utilized to treat biofilm after the wound had been debrided. And we found that in some cases, silver, cadextramyr iodine, or even surfactants could be of benefit. Okay, and they're still working on this. There's still a lot of research to be done. We were involved in a very, very small study actually looking at bromelain-based enzymatic debridement as well. We found on a very small cohort of patients, was 12 patients, we found that the biofilm dramatically reduced with this therapy. So again, I think there's a lot that we need to learn, but we're working towards that. So the take-home message is really very simple. A biofilm is really a complex, very synergetic bacterial force between numerous bacterial populations. The presence of biofilm really is confirmed as a true deterrent to wound healing. Sharp debridement opens this window of opportunity. But again, keep in mind that you have an opportunity that closes very quickly, and this biofilm can reform as a completely mature biofilm, certainly within 24 to 72 hours, and topical agents are certainly being studied to determine the effect of wound biofilm. So I thank you very much for your time.